Yes, hello, Robert Bastian here again. Kim and Charlie asked if I would answer some questions that we couldn't get to during the original webinar. They sent them to me, and there are an awful lot of them. I'm afraid my answers may frustrate in some cases simply because I don't have very much context for the question and I don't have the voice in front of me. As you could tell from my discussion, I use vocal phenomenology a great deal. And furthermore, sometimes I don't always agree with the diagnosis that happens elsewhere, and I'm sure maybe somebody elsewhere doesn't agree with my diagnosis. So with that caveat, let me just plunge in. There are an awful lot of questions, so let me just see how many I can get through. Here's a question. Are dystonias related? If you have one dystonia, are you more likely to have another dystonia? And the person's referencing having SD for years and now having some pain in her hands and arms. The answer is yes, you can have another dystonia. Most people, once the spasmodic dystonia has settled for about 6 months, that's more or less what their whole dystonia picture is going to be uh, on an ongoing basis. But it is not rare for people to develop a little bit in a hand in particular. I have patients who say, my hand works fine in most circumstances, but when I try to write, my hand has gotten a little shaky and it jerks and it does funny things. So that would be a larynx and a limb dystonia. So that I've seen quite a few times. Um, but I would say most people you should just expect once you've settled with your original dystonia, most people remain more or less the same. And then a question, can you have both AD and AB? Yes, that's what we call the mixed dystonia, and I mimic that on the webinar itself, but that's where the voice is both grabbing like that and also dropping away to a whisper. So a person would sound like, long ago, people found that it was easier to travel on water than on land. So you hear the mixture of dropping away to a whisper and grabbing and clamping, cutting out. Here's a person who says, uh, I have breathing issue, which I have involuntary noises, breakup of the voice when speaking. Uh, so I think what I'll focus on there is the idea of the involuntary breathing noises. Remember, I said in the webinar that there is a subvariant that I just call respiratory dystonia, and I mimic that idea that the airflow, instead of coming in a smooth flow and out in a smooth flow, it comes in sort of pieces. It's what I call breathing in little packages or little pieces. So breathing in would be a kind of a and that's way louder than it usually is, but you get up close and you can hear these little, I don't know if you can hear that, but a little, you can just hear those little noises. And if it's expiratory, then you'll hear the, so the air is being let out in little pieces rather than in one smooth flow. That's respiratory dystonia, and it is handled with Botox. Sometimes the dose has to be higher than we would prefer for voice reasons. In other words, to get good respiratory relief, you have to accept a little bit more weakness of the voice. The dose is higher than we would normally like just to fix or to treat the voice. Uh, can dryness make SD worse? Well, SD can be made worse by stress, fatigue, uh, who knows, maybe salty food. Because it varies so much, people are typically searching to find out, well, what is it that made my voice worse than or better than or whatever. So I can understand why a person might ask the question, does dryness make it worse? But it's hard to answer that definitively because almost anything can make it worse. It's varying. People are having good moment or bad moment and so forth. Um, somebody asked about flying and a change. And again, I would just say that psychological states, it just, it varies so much for whatever reason. That is not your responsibility. It's just a part of the disorder. That flying, I'm trying to think of something about the change of air pressure or the dryness of the air cabin. Uh, 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 it's hard to know, but I would take your experience at face value. I am sure that that is what happens, but I just can't give you for sure a reason why when you land after flying your voice is so much worse. Um, Here's a question about speaking more than one language, and that if a person is fluent in two different languages, is it possible for them to have more or less difficulty depending on the language? And the answer to that is yes, because the sort of list of sounds that come out with one language are a little bit different than the list of sounds with the other. We know that that if you take a person like me and you who with SD and you put on a fake accent, you can make the symptoms subside. So I don't wonder at all. You can do nursery rhymes and it works better. So that's all in the realm of these sensory tricks. Um, Task specificity, uh, fake accents, nursery rhymes, raising the eyebrows, using a very sing-songy voice, like reading to children long ago and far away. That all of those things can affect symptoms, um, and those are things that sometimes people can harness, um, at least for certain moments or conversations, but they are not, unfortunately, as a long-term solution. But I don't think you're wrong in if you're finding that speaking French is not as troubled as speaking English or vice versa. MTD, there were a few questions about that, and I have a real problem in answering because you have to begin by saying, well, what do you mean by MTD? When I speak of MTD, I mean it in the original classical description by Ramage and Morrison. It is not a neurological disorder, it is a laryngeal posturing abnormality that is detected and bothers the singing voice more than the speaking voice. So it has entered the realm of spasmodic dysphonia inappropriately, in my view. I would not use the term MTD. I would use the term tonic variant. So when a person has SD, but it sounds just tight all the time like this, you don't hear a lot of phonatory arrests. There are people who have SD who sound kind of like this. They really are not catching or stopping, but that is SD. I would call that tonic variant SD and not MTD. It's too confusing to define MTD in two completely different ways. So it's a posture disorder. MTD is, it's a posture disorder in the larynx, primarily in the laryngopharynx, I should say, and it's a speech therapy problem. MTD in the SD realm, usually people are using that term to describe what I would call tonic variant, the sustained over closure, not the catches and stoppages. Normal, let me think. Normal dosage, it varies a lot. There's a big variability in dose requirement between different individuals. I would say our average dose is about 1.25, and in my clinic, when patients and I talk about dose, we're always talking about the total dose. So if I say to a person, your dose today is 1 unit, we just have an agreement that that means a half a unit per side. Uh, um, because almost everybody is a bilateral treatment, I just use the total dose. So total dose of 1.25 would be average. Our range goes from about 0.25 to 5. So a lot of times we use money as an analogy because there are people who are not into decimal kinds of things. And so I say our average dose is $1.25. Our dose range is 25 cents to $5. And the the common group, the bulge of the bell-shaped curve is 50 cents to $2. So it varies with different individuals. You can have a 6'4" football player who needs 25 cents, and you can have a 5 foot tall, 95 pound, 80-year-old woman who needs $3.50. So it's completely specific to the individual. Everyone's got a personal kind of dose requirement. I have ADSD with tremor. Boy, this is a question I'd like to answer, but I don't really get the context, and I'd need to hear the voice. Yeah, there are people who have laryngeal dystonia who very unfortunately, after a number of years, add in a great deal of tremor. I don't think the audience here should worry about that because it's an uncommon. It's not rare to add some tremor, but to add tremor to the point that the tremor component is overwhelming is very uncommon. So I wouldn't worry about that. But if a person leads with the tremor, they have some spasms, but the shaking is sort of the main thing you hear, that can become quite hard to treat. My doctor is having trouble getting consistent Botox shot placement, moved to having a second doctor scope you to get a proper placement. I think you have to find the best doctors in your area, and then there's a certain extent to which you need to allow them to do whatever it takes to make it work for you. I personally wouldn't do that. I just wouldn't find it necessary, for one thing, and I would find it so cumbersome to be scoping and injecting. The EMG guided technique works extremely well by itself. So it sounds like a lot to do to get a good result. But if that's what it takes, then I imagine you should do that. Here's someone who says, I've had SD for years and years and responded enough to Botox that I can keep working. Will it get worse though as I get older? The answer I usually give people to that is Botox continues to work well regardless of how bad the spasms are. So my longest patient, I think, is about 33 years and still doing extremely well. So if a person's underlying SD got worse, I wouldn't worry too much about that. The exception is tremor, the addition of tremor, not a little tremor, but I mean if it's a tremendous amount of tremor, which again is not common. If anything, I would say there's a pretty good group of people who have been treated for many years with Botox who become milder. The way I describe that is that the ditch that they go into as the Botox is wearing off is shallower. So some of those people will say, I can come less frequently, and the reason is they're going deeper into the ditch. They're going a greater distance into the ditch than they used to, but the ditch is shallower. They used to go good voice to a ditch that's way down here, and now they go good voice to a ditch that's only here. And so this seems in their memory like the Botox is still working, where in actuality the ditch is just shallower. I don't know if that made sense, but there it is. So I'm always hoping that the dystonia will evolve in the patient's to the patient's benefit. That does happen. Can you get too old to take Botox shots? Not in my experience. My oldest patient so far was actually, I think she just turned 100 when I did her last shot. And I have lots in the 80s and 90s. So no, you're not too old ever to get Botox. I've had abductor SD, that's the dropping away to a whisper, and now I want to try Botox. Do you get better results injected under general anesthesia? Local factors here, you have to figure out who your doctor is, what their experience is, and what is going to work better for them and consequently for you. For me personally, much easier to do in the office. I wouldn't want to do it under general anesthesia. I think that would actually be harder to get to the muscle. But the abductory SD injection is technically quite a bit more challenging than the adductory. The 9 out of 10 kind of injection is quite straightforward. I mean, it's got its technical challenges, but once a person, figures it out, it's pretty straightforward. The abductory, that's 1 out of 10, is technically, it's much harder to do, but you can get quite good at it also. The caveat is that for some reason, people still insist on going at the problem muscle laterally. I personally think to come at that muscle from anteriorly works much better. I wrote an article on that quite a number of years ago. And so I wouldn't do it in the OR, I wouldn't do it laterally, I would do it anteriorly, but your doctor could disagree. For abductory SD, do you feel that Botox can be successful? Absolutely. We have quite a number of people with ABSD who come routinely, and I can't think they would do that if it weren't really helping them. But again, it is the more challenging of the two shots. I've been living with ABSD for several years now, and your specialist explains it's the most severe he's ever seen. I've been trying Botox for 18 months in the PCA muscle, but the arytenoid is always 1.2 millimeters from midline. Now, again, here's where I don't quite have the context. I think what you're saying is that after the injection, there's an effect because the vocal cords get quite close together, but maybe the voice still isn't very good. I had one patient like that years ago who, when he exhaled and inhaled rapidly, remember that's my test of sufficient dose, is if you get an AB injection and then a week later you go, and that's what it sounds like. We can't make any judgment about whether Botox is useful for you because it's not a sufficient dose or it didn't hit the target. You have to hear something like some kind of a noise. It can be quiet, it can be even louder than that, but if you don't get any of that, you can still breathe in rapidly with just the air rushing sound. There's no voice, there's no voice sound in it. Then I can't tell you whether Botox is going to work for you because that's an insufficient dose. So you shouldn't ever say Botox doesn't work for ABSD or it's not giving me any benefit unless you make that noise. If you make that noise breathing in, I don't mean you try to make that noise. I mean, try as you might, you can't not make that noise. I can go, and I can't stop that noise from happening. Whereas now I can go, no noise, but rushing air. So if you, sorry, I'm being a bit repetitive here, but if you can breathe in rapidly like I just did without that vocal noise, the question is, we haven't answered any question about Botox because it didn't give you the effect. We have to have an effect on breathing before we can judge the effect on voice. Now, I've been getting Botox for 20 years, found that choking on liquids is actually a chronic condition. Here again, I don't have the full context, but the answer to that is if you're saying you get your Botox shot and at the beginning of every injection cycle, the first week or 2 or 3, you cough on liquids, then my next question would be, how weak is the voice? Because there's a little correlation. People who get a very weak, breathy voice like that are far more likely to cough on liquids than people who have the sort of preferred degree of weakness, where it's noticeable that you're weak, but you are a little more functional. So if you're getting that early result and coughing on liquids, that's a bit unusual. If you're getting this early result and coughing on liquids, that would be almost expected. And I would think of that as, at least we would discuss lowering dose. What is needed for Botox to be approved by the FDA? It isn't really necessary. I think the American Academy of Otolaryngology and I think it's the American Academy of Neurology have both put out position papers, but we have not found much of a problem. Sometimes we have to write a letter. So with the appropriate letter from your doctor explaining to the insurance company the problem, I don't know that it is going to be that important that the FDA ever approve it. Just like I'm not sure that aspirin has ever been approved for as a blood thinner. It may have been, but it's sort of immaterial because you can use a medicine off label. It's not experimental anymore. It's just an off-label use. So you do sometimes have to be a little assertive with a new insurance clerk somewhere who just looks at a list somewhere and says, "Oh, this is not approved." So you write a letter, you write an appeal letter. I don't mean you, the doctor does. Then the doctor's does a peer-to-peer kind of a discussion. But it's been years since I've had much trouble with that kind of thing just because it's such a well-known use for Botox. When Botox, sorry, I've always had breathing problems with mild stress. I wonder, yeah, it's hard to know. This is a person with Meja syndrome and craniocervical dystonia wondering about breathing symptoms. And the answer is you can have isolated respiratory. So you can have laryngeal dystonia that doesn't really affect your speaking voice. 99% of people with laryngeal dystonia, it affects speaking. So that's the function that is interfered with, but rarely there is a person who says, I have no trouble talking, I have trouble breathing. So the spasms are initiated on the respiratory side rather than on the phonatory side. So that can happen. And again, you listen for that segmentation, that sort of cutting of the smooth flow into little packages or little pieces of inspiratory or expiratory air. So if Botox is administered and it doesn't hit the spot, the vocal cord muscle, what happens to it? Well, Botox is not active in fat or skin or ligaments. It's only active in muscle and in non-myelinated nerve fibers. So mostly it would just go somewhere and just dissipate. And keep in mind if you're injecting and you are doing AB and you're doing it from laterally, you can get the Botox into pharyngeal musculature, at which point you're going to notice some swallowing issues, but that's injected into another muscle. But if it's not in any muscle, there would be no effect. The dose is so tiny that it wouldn't, go anywhere else in the body to any degree that it would ever be detected. It's just kind of lost in space. Now, what do you mean by high quality shots? The way I define high quality shots are available on demand. You are a person with a life purpose. You have work, you have family, you have community involvement. And so when you need your voice, you need your voice. So you need to find a place where they can get you in promptly when you need the Botox. So to be told, well, we're not injecting again for 2 months, that doesn't work. We can inject actually every day of the week. We tend to clump people on Fridays and Saturdays, but if someone arrives on a Tuesday from 2 hours away and we didn't know what the diagnosis was, they're a new patient, we can inject them on a Tuesday. So I think that to be told you have to wait more than a couple of weeks is stretching it. So available on demand. The injection itself needs to be done in a sort of slick way. I mean, it is a shot, but you want to end up with 1 or 2 little tiny red dots and no bruise. And it needs to happen sort of quickly and efficiently because that makes you the least uncomfortable. And then the dose has to be appropriate. if you're told, oh no, you have to be Minnie Mouse for 2 weeks after every injection, not a high quality shot, because how can you be an attorney or a teacher and have to put up with this kind of a voice for 2 weeks? That's not a high quality shot. And then finally, the result needs to be somewhat consistent. Nobody can be perfectly, you can't get exactly the same result every time, but you should be able to count on, okay, I'm going to get a result. So available on demand, done in a sort of slick way, skillfully, uh, the dose appropriate, and a reasonably consistent result, and a doctor who's willing to help you meet your purposes. In other words, you're kind of in charge of saying, here's what I need out of this injection. That's high quality. Complete loss of singing from just one Botox injection. That is a place where I could only speculate. I can't think of why that would happen with a routine Botox shot. So I would need to actually hear the deficit. So we would elicit a lot of singing voice tasks to hear what it is that's missing. Is it the upper range? Is it stability? What is it? And that would help me know whether it was some kind of damage from the needle. It wouldn't be from the Botox alone, though, I don't think. Um, what about Botox shots generating at least 3 weeks of aphonia and not compatible with work? Well, that is purely a dose issue. You simply need to tell your doctor, hey, I need a lower dose, please. Uh, you need some initial weakness where family and friends might say, oh, you must have had a shot, but you want to still be able to work and function and talk on the phone and everything. If you're getting whisper, that's way too high a dose. Um, Botox hurt like uh, hell and took an hour and left me with esophageal issues. Again, I'm lacking the context, but I suspect this person is talking about an abductory SD injection and that the injection was from laterally, where if not targeted perfectly, the Botox can make its way into swallowing passage and cause a lot of swallowing issues. That would be solved by an anterior approach. It's not, that's Botox got into muscles that were not intended. Um, I am the person with no effect and no benefit or effect. Uh, if no effect, you kind of need to persist. You have to get an injection that has an effect before you can judge whether there's a benefit. So if there's no effect, I would say I don't know whether you can get a benefit out of Botox because we have to get an effect before we can judge the benefit. Um, so I don't know whether it's dosage or accurate targeting or maybe even an antibody. If your doctor is quite sure of targeting and that the dose is sufficient, then I might have them do an injection right here. You know how you can make the frown crease right there. So you get some Botox put right in there, not for cosmetic reasons, but because it's a very easy place to see whether there's an effect. Um, and if there's no effect there, then it suggests maybe you have an antibody. Um, the differential diagnosis between spasmodic dysphonia and essential tremor. Essential tremor is just the wavering. That's essential tremor. There's no spasmodic dysphonia with a large tremor component would be where you hear the interruptions and the variation of the tremor. Other treatments, medications and treatments that are shown to be helpful. I had a seminar one time of 80 patients, and there was someone who, in a Q&A session, said, clonazepam, it's wonderful. So that makes me say, try things like clonazepam. Um, Ask your neurologist if you are motivated to do that. But in my experience, oral medications, with the exception of the benzodiazepine like clonazepam, are not very useful. And I don't use clonazepam throughout. There is an addictive potential to benzodiazepines, but I have a few patients who use clonazepam as they're going down into that trough, the ditch, the bottom of the ditch, and they have important things happening, but their shot isn't for 2 days. They'll sometimes take a small amount of clonazepam, but there are lots of people who say clonazepam does nothing for me, so it's an individual. Fillers. Fillers are not really a treatment for SD. I say that with the disclaimer that every patient is unique in some way, and the treatment for everybody should be individualized. So I don't want to say there couldn't ever be a circumstance where maybe a filler had some role. Not sure what that might be, but just so you know, fillers are not a typical treatment for SD. Vibrotactile, University of Minnesota is doing work on this in their bioengineering department. The thought is to, I think it's sort of to fatigue or reset muscle spindles. But the other question is it simply a sensory trick? Meaning, somebody has cervical dystonia and their head is turning, you tap on their forehead and they can move their head around. And when you stop tapping, then the head goes over again. Or the person who says, I talk better when I jam my thumb up underneath my chin, that's a sensory trick. So is vibrotactile having that sort of effect? I'm hoping that it's going to pan out. And I'm feeling bad because I wanted to help them with a study on that, and the flesh is, the spirit is willing, but the flesh is weak. It's just a matter of time. There are a few specialists performing surgery for AB, very expensive, and I have mixed thoughts on the effectiveness. Having treated, how many ABs? I would think maybe close to 100 across my career. We get quite good results for the majority of them with Botox. Again, challenging, and I use an anterior approach. But I think I've had maybe a half a dozen where I can get them doing that. So they're making the noise. I know I hit the muscle and it's a sufficient target. When they get that, but their voice is still very, very poor. It's like it's a kind of an effect, but not much benefit. In a few of them, I think about 6, I have placed bilateral implants. The idea being to firm and insist that the vocal folds are closer together. And in all but 1, there has been some benefit. I don't know whether it's really a mechanical benefit or it's what I call a change the system kind of benefit, but it's not something I go to early or easily. It's in that really severe AB that we've done Botox, we're sure we've hit the target, we're sure the dose is enough, but they're just not getting much voice benefit. Could Botox for migraines have caused my SD? I would say a qualified no, because no, I don't think so. Do you have to get Botox injections first before going to a surgery option? Again, I would say individualize. I don't like to make blanket statements for any individual, because you again have to match the patient's circumstance to you match the patient's circumstance to proposed treatment. You don't match people to a checklist. So I would say most people who are working with SD, though, will tell you that if you can get a good result with Botox, that's probably the way to go still for now, rather than opting for surgery. Surgery always has a slight degree of uncertainty associated with it, and there's always a slight risk as well. If we could see the future, we would know, yes, you should do surgery, but the ideal, in my opinion so far, is if you can get good results with Botox and can come 3 times a year, sometimes 4 times a year. You walk into the office, there's this procedure done that's a bit unpleasant, but it's efficient and it's quite effective and quite predictable. Then that's what I personally would do if I had SD. But again, individualize. Had SLAD-R and have a hard time swallowing liquids ever since. I choke and aspirate. The SLAD-R was not effective for me. Well, I would need to see about that swallowing on, coughing on liquids. I'd need to see your larynx and what the mechanics of this choking are. And so that would be my answer there. I don't know why SLAD-R would give you permanent choking on liquids unless your vocal cords are unable to close, in which case there could be things that might be done, but it really depends on a very clear understanding of why you're choking on liquids. Sd and Parkinson's, I've had SD, I've had AB, SD for 30 years. Most effective treatment has been speech therapy. Recently been told I have Parkinson's disease. And after getting on carbidopa-levodopa, my closest family and friends noticed that my voice is much improved. I mean, easier to understand. Well, there is a laryngeal dystonia that goes with a oh dear, I'm blocking on. I have one patient who had definite laryngeal dystonia. It was DOPA responsive dystonia. That's what it's called, I think, DOPA responsive dystonia. And so it could be that was your diagnosis and it just wasn't recognized for a number of years. And now that you're on the carbidopa-levodopa, you might ask your doctor, do I have DOPA responsive dystonia? Which is rare in my experience, but it does exist. Now, is there any connection between SD and Parkinsonism? The way I say that is they are related in the same sense that a motorcycle and a semi-truck are related. Both a motorcycle and a semi-truck are vehicles, but one doesn't relate to the other than just that they're vehicles. So both SD and PD, Parkinson's disease, are neurological, but they aren't related to each other. They're both related to neurological, but they're not related to each other. I've heard that SD leaves you at a higher risk of developing Parkinsonism in, I would think, maybe as many as 1,500 patients across 33 years. I have not seen any connection between the two, any higher risk. Just not my experience, and I would guess I would defer to a neurologist to answer that question. Then there's something about SD and Charcot-Marie tooth. I have one patient that I've treated, I would think 20 years at least. No, it's longer than that, 25 years. And he has Charcot-Marie tooth and he has dystonia, but he's the only one. He gets great results with Botox. Have you seen acute COVID onset SD? I have not, but keep in mind there are millions and millions, tens, hundreds of millions of cases of COVID, and and people are getting COVID more than once. So it wouldn't, I mean, if you just think about it, SD has to begin at some point. So if in millions and millions of people somebody notices it after COVID, the question is, did COVID turn the switch on, or is it just a correlated in time but not necessarily in causation? In other words, there was a full moon, I looked at the full moon, and the next day my SD started. There's a relationship in time, but is there a relationship in causation? I think it'd be very hard to know. Now, having said that, when you do ask people about the onset of their SD, a fair number of them do talk about a antecedent viral infection. That's been for 20 plus years. I've noticed that it's not 100% of people, but it seems to come up. But then, of course, upper respiratory infections are fairly common too. So is it just related in time or in causation? And the vagus nerve relationship to SD, well, the spasms are communicated through the vagus nerve. That's the 10th cranial nerve. They're mediated through that nerve, but I don't think it's a nerve disease. It's more of a basal ganglion or a central nervous system kind of disorder. Wow, that was a lot of questions, and I hope those answers weren't too superficial. Maybe this could be cut into 2 different videos, but hope that helps. Bye-bye.